People ask if there are any symptoms or way of detecting prostate cancer early. The answer is that there aren't any symptoms that are directly related to prostate cancer, unless, of course, the prostate cancer is very advanced and the prostate cancer starts to interfere with the manner in which the bladder empties. That's very rare, and we hardly see that at all these days. Most prostate cancers, by the time they're diagnosed, are diagnosed when they're about the size of a pea, and obviously a cancer of that size isn't going to affect the way that you pee. Having said that, men as they age get problems with their peeing. They go frequently, urgently, they get up at night, they go to their doctor, and inevitably they get referred to a urologist, and a urologist then assesses the urinary symptoms but also assesses prostate cancer risk. So those individuals are likely to get diagnosed if they have prostate cancer. Because there are no symptoms, this is why there's so much interest in screening, and we're having lots of discussions at the moment about how we would detect prostate cancer given that there are no symptoms that are associated with its presence. And currently we're looking at things like PSA, but more importantly things like imaging with MRI as methods of early detection of prostate cancer.
Hello, my name's Paul Edgerton, the UK Men's Shed Association Ambassador on the Health and Wellbeing Advisory Group. I'd like to welcome to our discussion today Professor Mark Emberton, the Dean of Faculty of Medical Sciences at the University College London, and who also holds a number of appointments at that hospital as well. Welcome, Mark, and thank you for joining us today. I wonder if we'd like to start. Would you like to say some words before we get into some detailed questions, which we've prepared beforehand from various sheds across the UK that have come to us with some things that they need to know on prostate cancer?
Well, just to say thank you to both yourself, Paul, and to the association. I really enjoyed my last meeting with the association. And what's been fascinating is that since we got together last time, I've seen many patients who were inspired by the last session we held, which was me lecturing and answering a few questions afterwards. And they told me just how important it was that they saw the content of that presentation, and possibly more important, the question and answer session afterwards, to encourage them to go to their GP and get checked. So there will be many men around the country that acted because of the last session we did. I've seen some of them, and that's proof that that sessions like this make a difference. So I'm honoured and delighted to be here again. So I work at, I do my urology at University College London hospitals, and I do my research at University College. Now they sound very similar, and there's an H that separates them, but University College is the university, which is separate and different to the hospital, which is obviously an NHS hospital in central London. But obviously we work together very closely, and we try to do the research on as many of the patients that we're treating in the hospital. But delighted to be here.
Thank you. A number of questions we've received center around the pros and cons of PSA testing as a method of detection. Some GPs we've heard of are very anti-testing. Could you say something around PSA testing, what it is and why it's useful as a pointer?
Yeah, so PSA is a blood test, prostate-specific antigen, and the clue is in the name. It's a test that is specific to the prostate, but not to cancer. So many things can push the PSA up. Sexual activity, a long cycle ride, a digital rectal exam, prostatitis, which is inflammation of the prostate, a urinary tract infection. PSA is also higher in big prostates, and it also goes higher as a man gets older. So one can immediately see that there are things other than cancer that can push your PSA up. In fact, when we see a man with a high PSA, it's more likely than not that the PSA is elevated for reasons other than cancer. and so there are false positives with PSA. So it's high and not due to cancer. Usually that's because the prostate is on the large side. And equally, we're finding now men who choose to have an MRI, who might have a low PSA. We're finding that a proportion of men with low PSAs who would not have been referred to the GP or urologist do indeed have clinically significant cancer within the prostate. And we know, when we biopsy these lesions, they're pretty large, and presumably they come under the threshold for PSA because that cancer doesn't make PSA. So not all cancers preserve the gene that makes PSA. I should add that PSA is the substance. It's an enzyme. We call it a serine protease. Its job is to liquefy semen. It's present in very, very high concentrations in the semen, and only a small amount of it leaks out into the bloodstream. And that proportion that leaks out in the bloodstream can be affected by all the things I've said. So if you've got a bigger prostate, more PSA producing tissue, you might get more leakage than if you have a small prostate. If somebody squeezes the prostate, or you have sexual activity or cycle ride, etc., that might force a little bit of this PSA into the bloodstream, and that's where we measure it. And so we're looking for a slightly elevated amount of PSA in the bloodstream, and we assume that some of those patients will have prostate cancer elevating it. But as you can see already, if you use PSA as a test, a lot of men will come forward for testing who don't need to be tested. And we will also miss a lot of men who have clinically significant cancer, whose cancers do not express PSA. So it's imperfect.
And would you reckon, I was going to say,
there is no perfect test in medicine, and it's better than doing nothing. Mm-hmm. And we know that the use of PSA, on average, despite its flaws, will identify men with prostate cancer, and if treated, we know that we can reduce the death rate associated with prostate cancer, and there are a bit large studies that have shown that.
Yeah, I was going to ask, would you recommend that men of a certain age undertake PSA testing as a matter of course with their GP?
I do. They just need to know, like anything that you do in medicine, a little bit about the test that you're going into. Mm-hmm. So not to rely on it too heavily, because it's imperfect and there are false positives and false negatives. If a man is having a PSA over time, let's say a PSA, from the age of say 50 or 55 once a year, then one can start to use the trend. And if the PSA is going up at a rather faster rate than we'd expect, then that's also a red flag for prostate cancer. So PSA as a kind of one-off test across a population may be quite imperfect. Within an individual over time, its performance gets much, much better because the individual serves as his own control. And if you do a PSA, whatever level it is, and it stays flat or goes down, that puts you at low risk of prostate cancer. If it goes up at a rate that is incremental with time, so that is much more likely to be due to cancer. So PSA, if you watch a group of men age, tends to go up by 0.2 micrograms per liter per year. So by 1 whole point every half decade. And we know that, and we adjust for that. And the cutoffs of PSA, as many people listening will know, is often expressed in an age-adjusted manner. So if you're very young, a PSA of 2 or 2.5 will trigger a referral. If you are over 75, for instance, a PSA of 6.5 will trigger a referral. And that helps the PSA behave slightly more accurately. So it improves the sensitivity and specificity of the test in line with the age of the individual having it.
Mm-hmm. Thank you. Right. Going away from PSA testing, one of the questions that we had, which you may have come across, are there provisions for testing transgender adults where men have transcended towards women, Presumably, some still have internal organs that may be vulnerable to prostate cancer, although they have the outward appearance of being a woman.
Yes.
Is that the case?
Yeah, very much so. So historically, we've talked about men with prostates and prostate cancers, but we have to broaden that, and we just need to talk about people with prostates and possibly prostate cancer. And of course, if you have a prostate, you are at risk, just like anybody else. It doesn't matter, whether you call yourself a man or a woman, you're still at risk. And of course, all urologists are now aware of this, and will make special provision for testing in somebody who has defines themselves as a woman but still has a prostate in place. Now we need to do that cleverly, because some individuals will be on hormones, and that will affect the PSA expression. And so imaging is probably the best test to do in somebody who has a prostate in place and is exposed to hormonal manipulation.
Why is there no UK-wide scanning undertaken for prostate in the same way as bowel cancer?
It's a great question. I mean, bowel cancer has changed as well. The screening for bowel cancer, has had there've been many different attempts to do it, and as many people know, I was invited for a screening sigmoidoscopy about 5 years ago, I think, because that was part of a trial. And we used to do fecal occult bloods, and now we do the FIT test, which is very, very accurate. And many people listening will send that in the post. You put a little bit of feces on it, you send it back, and you get an answer amazingly within 28 days. It's a fantastic system. So all screening tests are refined, and old ones are replaced by new ones. Not so good tests are replaced by better tests all the time. So it's quite interesting to see the evolution. I mean, people have also tried screening with low dose CT, but that doesn't really work across the population, and that might be better for at risk individuals. And prostate's no different. We used to screen with a finger. Then PSA was invented, and we could identify men with prostate cancer earlier because of the PSA profile in that individual. We've now got imaging. We've got several biomarkers. There's even ultrasound now that, in its modern form, with increased frequency and with a bit of post-processing, is much better at identifying prostate cancer. We've got tests like PSMA PET. I don't think that's ever going to be a screening test, but that's very good at identifying clinically significant disease. It's an expensive test that involves an injection and radiation, so it would be implausible that could be as a screening test. But so there are many tests available. I think at the moment, looking at them all, probably our best bet for the future is going to be a very short sequence MRI, in which men have about a 10-minute scan, which has the two components within it that are the short ones. So it's the T2 and diffusion components, and the injection of gadolinium or contrast that then requires lots of pictures to be taken over time, is dropped, because that requires a doctor to be present in case you have a reaction to it, requires somebody to give the injection. You have to buy the gadolinium, you have to administer it, and there are some kind of health issues related to potential health issues related to gadolinium, particularly if used across the population. So I think that's currently looking like the best bet. Obviously, we need to put that to a trial. It's very good news that trial is being considered and may well run in the UK pretty soon. That will involve imaging plus other tests. And I suppose the big question is what combination of blood or urine-based biomarkers in combination with imaging is going to provide the best and most cost-effective way forward. Is it PSA first, followed by an MRI? Is it an MRI in conjunction with a PSA? Is it an MRI in conjunction with other biomarkers? and these will be put to the test across the UK. I think the UK will lead this. I don't think you can do this study anywhere else in the world currently, because the provision of MRI in this country is probably more advanced than nearly anywhere, I think, and we can exploit the setup in the NHS to do it. So I think we are going to try screening differently with an imaging-based test, and I think we will hear about a clinical trial hopefully in the next year, in terms of it being funded, and then maybe a year from then we'll start recruiting patients. So it's good news in terms of screening.
Indeed, yes. And I believe also that MRI scanning techniques are improving all the time.
Yeah, you're very well informed. And so we and others are kind of inventing new sequences. I have a colleague called Shonit Punwani who's invented a sequence that is limited to the T2 scan, which is quite useful because the T2 scan isn't affected by having a hip replacement. It isn't affected by gas in the rectum, and so it's very resilient to distortion, and that's good for screening, and it's just a special way of analysing that. And we look at the ratio between prostatic tissue and the lumen, which is the part of the gland or the duct that contains the semen, and obviously that architecture is changed by cancer. And the more it's changed, the more likely it is that the MRI will come up with a positive signal and indicate that cancer is present. Now, if we could get it down to 5 minutes on a T2 alone, you don't need a doctor present. You could set these scanners up in a supermarket, in a shopping centre, on a truck, and you could scan because of the simplicity of doing it. You could scan easily, 5 patients an hour, so you could make it a really cost-effective intervention. Mm-hmm. And I think screening will look something like that in the future.
It certainly sounds like an exciting area of development.
Yeah, no, we're really excited, and actually, it's really interesting because the MRI picks up disease that you don't pick up with PSA and biopsy. It also avoids the problem of overdiagnosis. In other words, finding these tiny bits of Gleason 3+3 cancer, which probably doesn't impact on anybody's life expectancy, because you're looking for abnormalities within the MRI, and it's those abnormalities that you will either observe or subject to a biopsy. And we might come in. I think we're going to come into this later. As once you've got an image of a lesion, then you can start doing artificial intelligence feature extraction of it, and you can start deriving lots of information about the nature of that lesion that goes beyond of our ability to see. And we may get to a point where we can advise men, without recourse to biopsy, which I think is the running title of some of this discussion.
Yes. Well, which actually brings me nicely on to a question that, for me at least, is how can early diagnosis impact outcomes and the prognosis for someone who becomes diagnosed with prostate cancer?
Well, I think the answer is in lots of ways. So obviously, the earlier you find a cancer, the less there is to treat. And the lower the propensity for developing metastases. In all cancers, the risk of spread relates to the volume of the cancer, which obviously represents the number of, or how many millions or hundreds of millions of cancer cells are present. If you can see a cancer, there's normally about 100 million cancer cells present. If you can't see a cancer, you're dealing with a much smaller lesion. So catching a cancer early means that you catch it at a time when spread is highly unlikely. So, affecting a cure, in other words, long-term remission, is going to be a lot easier to achieve. And also, if you catch it earlier, you depending on the way that you're treating it, you may be able to get away with less treatment. So in other words, it may be that the individual does not need to have the whole prostate removed, or doesn't need radiation to the whole gland, because if one can see the cancer and it's tiny, 5 millimeters across or something like that, again, the size of a pea, which I think I referred to in the video at the start, it might be possible just to treat the area of the cancer plus a margin, and to do that in a very simple, quick manner, without the side effects that are associated with much bigger treatments, such as prostatic removal or irradiation to the prostate or hormones. So I think catching a cancer early gives you lead time, and that allows you to treat the cancer when spread is highly unlikely, but it also allows you to do different things. And for me, as a researcher, that's the interesting thing about early detection. It allows us to treat the cancer at such an early time that it makes no sense to remove the whole prostate. One can just treat maybe 5 or 10% of the prostate tissue to get rid of the cancer, and that's obviously very exciting, and that's bringing a whole new kind of pattern of treatment for men with this disease.
So for us in sheds, when we get talking about these things shoulder to shoulder with other shedders, it's the catalyst that we need. For goodness sake, go along to your GP and get yourself checked out.
I think that's right. You can't wait for a symptom with prostate. If you have a symptom that can be attributed to the prostate cancer, it's too late. The prostate cancer is so big that it's either spread somewhere and giving you pain, or it's blocking the urethra. And you need quite a big cancer to block the urethra. It has to be 2 or 3 cc's in volume to kind of put pressure on the urethra. And so if you wait for symptoms, you will be diagnosed late. The only way currently to be diagnosed early is to get a PSA. If your PSA is less than 1, you've probably got nothing to worry about. If your PSA is above 1, it depends how old you are, and it depends how big your prostate is. We haven't talked about PSA density. PSA density is a really useful PSA derivative. And what it does, it adjusts PSA to the underlying prostate volume. And so a big prostate, so let's say a prostate of 100 cc's is allowed a PSA of 10. If the prostate measures 30 cc's, it's allowed a PSA of 3. And a PSA of 3 on a 30 cc gland is perfectly acceptable. A PSA of 10 on a 100 cc gland, again, is perfectly acceptable. So the PSA density gives us some notion of how much PSA is being produced per unit volume. So it personalizes your own PSA. Unfortunately, to work out how big your prostate is, you either need to have an ultrasound, and that doesn't have to be a transrectal ultrasound. It can be a kind of external body ultrasound, which is reasonably good at not perfect, but reasonably good at estimating volume. Or we typically estimate volume at the time of the MRI. So almost every MRI report, so when the radiologist looks at the MRI of the individual, the first thing they do is they measure the volume of the prostate and record that, and from that we work out a PSA density. A PSA density of less than 0.15 is good. A PSA density of greater than 0.15 is bad in terms of prostate cancer risk. So what you're after is a PSA density of less than 0.1. That puts you at very low risk of having prostate cancer. So there's a lot we can do with PSA and knowledge of prostate volume. And once you know your prostate volume, it's going to stay like that for about a decade. Obviously, prostates get bigger with time, unless you're taking hormones to stop that process, such as finasteride or stronger hormones. And so once you know your prostate volume, you can work out a PSA density probably for about 5 to 10 years in a valid way.
Yeah. Are there any symptoms beyond the need to wee often that reveal themselves?
So urinary symptoms are much more likely to be due to benign processes in the prostate, in the bladder, in the kidney, in the individual, rather than prostate cancer. So if you wait to have peeing problems before you go to your doctor about prostate cancer, it's too late if that's due to prostate cancer. So most urinary symptoms are caused by a mixture of prostatic enlargement, which is a benign process, an aging bladder, coupled with lifestyle changes. So, it might be an individual's retired, they're now drinking a lot more tea because they're at home, etc., etc. And the caffeine and the volume that they're drinking has crept up on them slowly. They're presenting lots of water to the bladder. That's resulting in frequency and urgency, and some of that can be caffeine related. So the prostate has some role to play. The bladder, usually as we age, is the more important component in certainly in the men that I investigate. And there's always a lifestyle issue that we try and address. The kidneys are also important at nighttime. So as we get older, the kidneys are less able to concentrate urine at nighttime. And I've noticed it. If I have something to drink before going to bed, I get up at night. If I don't have something before I go
Yes,
to bed,
don't we all?
yeah. So my wife can drink chamomile tea before going to bed. If I do that, I'm finished. So I have to be careful, and that's a kidney issue, and that's a kind of kidney aging thing. And of course, sleep patterns at night. If your sleep patterns are poor, you're not sleeping well, you wake up, and the first thing you think about or aware of is your bladder. Once you start thinking about your bladder, you can't stop thinking about your bladder. So inevitably, you get up and pee, and that disrupts your ability to get back to sleep. It's also dangerous because you're walking around at night. You can't see very well. You might be slightly disorientated. Your blood pressure might be a little bit low because you've just gone out of bed. And there's an increased risk of falls, which obviously can be devastating if you sustain a fall in the bathroom and fracture something. So usually urinary symptoms are multifactorial. So there's lots of different inputs into them. If you come and see a urologist, the urologist will want two things done. One is avoiding ultrasound scan. So we get the individual to pee. We scan before, we scan afterwards. During the process of bladder emptying, we measure the flow rate, and then we look at the residual urine. How much urine was left behind after the void. Bladders have to do two things. They have to store urine at low pressure. If the pressure goes up, you want to pee. That's not good. And then they have to empty completely to do what they were meant to do. And obviously, if the bladder doesn't empty completely, if there's always 100 mils or 200 mils present, you're only using a little bit of your bladder, and that will result in frequency. So the ultrasound's the most important test. Actually, that's not true. The ultrasound's one test, and the more important test is the voiding diary, where we ask men to record everything they drink over a 24-hour period and everything they pee. So we'd ask them to record the time that they pee and how much they pee. And obviously they have to do that with a jug. And they do that over 3 days. It doesn't have to be consecutive days, but we know that each day is slightly different depending on what you're doing. And I find the frequency volume chart or voiding diary the most helpful tool in advising men. So there's little point in me seeing anybody unless both of those tests have been done, because once they've been done, we can have a discussion about the causes of the symptoms, and more importantly, what they can do to fix it without recourse to medication. Maybe you'll ask me about drugs that we can use to help men with peeing problems later on.
Yeah. A question that's just come in. What about sexual symptoms? I was T3B and had reduced semen volume as an example.
Yes, and I have seen patients who've presented with reduced semen volume. I mean that's quite a difficult symptom to elicit, because often the reduction in volume happens slowly, so men aren't very aware of it. And of course, seminal fluid volume reduces as you age. So it might be less useful a sign or symptom the older you are. So it might, if you're not producing much semen, and there's some men who just basically stop producing semen because they're just not making enough, then obviously it's going to be less helpful. But it is a rare but important presentation. And if somebody tells me that they've noticed that their semen has reduced, my ears prick up, and we go straight and do an MRI and find out why. It's interesting when you ask men after diagnosis whether they had noticed a reduction in semen. If you ask a direct question and they think about it, sometimes many of them can actually report that. Obviously, that will only be relevant for prostate cancers that block the ejaculatory ducts. If you have a peripheral cancer that's away from the ejaculatory apparatus, that cancer can become quite big without causing any problems. And so the cancer has to be positioned usually in the midline or obstructing one of the seminal vesicles, as I think we've just heard from our colleague. And that obviously, is relevant to quite a very small number of men, I think.
Mm-hmm. You made mention of drugs. Could you say something about drugs that are used to treat the condition?
Yeah, so the first thing I do, and so we're back to urinary symptoms which are not cancer related, just for those people that are coming in now. And what we can do, the first thing I do is see if there are lifestyle changes that we can use. Nobody wants to be on a drug forever, and if they can adjust lifestyle first, then that's by far the best thing to do. So sometimes we advise fluid reduction. If you've got a small bladder, you present less fluid to it. Sometimes we advise avoiding tea and coffee or reducing it, and that can have a dramatic effect. I've got patients who are cured sometimes just by stopping coffee or caffeinated drinks. The other thing that we do, and is some men just develop a small bladder over time due to bad habits. They pee before they go out. They pee when they get anywhere, and the bladder never really gets stretched, and the bladder gets smaller and smaller and smaller. And then we have to entertain in a program called Bladder retraining. And we often work with physiotherapists, nurse specialists to help individuals do this, a bit like going to the gym. And we teach men to overcome the first urge to void. So that first urge of, I need to go. If you distract yourself, that urge goes. It'll go away. And it's interesting, it might not come back for quite a while. And slowly that bladder's filling up. And then if you do that, you can train your bladder to hold on to more. And the other trick that you can do is pee into a jug and aim for 200 mils, 300 mils, whatever your target is. And that serves as very good positive reinforcement that you've actually now increasing your bladder capacity, what we call the functional capacity, the amount of urine that you expel. And some men actually keep a chart on the wall, and they can see that over time they've gone from 150 mils, which is a very small bladder. This cup contains about 300 mils to 300 and 350 mils, which is a very reasonable bladder. Most men, we try and get them to drink, so they're making about 50 mils of urine per hour. And so if you've got 300 mils bladder capacity, that's 6 hours of grace, and that'll get you through the night, reasonable night, get you through 2 motorway service stations, get you through a film. It'll get you through a lot of life's events. If you've got 100 mil bladder and you're drinking enough fluid to generate 50 mils or 100 mils per hour, you'll go on the hour or every other hour. It's pure arithmetic.
So in that context, are there ways that a person can reduce their risk of prostate cancer with diet, exercise, or anything else that would be helpful?
So I think the answer to that is is probably no. And I don't want to be nihilistic or depressive, because nobody quite knows when you have to start. Yeah, and so, does the intervention have to start when the person with the prostate is in his mother's womb? When does the cancer exposure begin? Most of us as children can't control what we eat. We're fed by others, etc., etc., etc. And most people will invoke a lifestyle change reasonably late in life, when they've had a prostate cancer scare, when the doctors told them to do something, and it's whether just changing things, age 55 or 60 or 70, when you've had 50 years of something else, makes a difference. Having said that, when I'm asked this question by patients, my response is very simple: is what's good for the prostate is good for the heart and also the brain in terms of reducing dementia risk. And it's staying physically active, it's keeping the weight off, it's eating well, it's probably drinking less alcohol, it's staying mentally active as well. And that's good for general health, it's good for cardiac health, it's good for mental health, and I think it's also good for prostate health. Whether a man then goes further and starts taking many of these supplements that are available, all of which cost about 30 quid a month, £1 a day seems to be what the world tolerates. They all have similar stuff: saw palmetto from the dwarf cactus plant, pumpkin seed extracts, vitamin A, E, often, selenium, zinc. They all have a very similar profile. That's an act of faith, I think. I take vitamin D in the morning. I just choose to do that. I don't take anything else. If an individual chooses to take a prostate supplement, I'm happy with that. But I think that's an individual choice, as we don't have evidence with which to guide that decision.
So really the message must be, as with all health issues, is to have a healthy and balanced diet, and to keep at it, and not just sort of have a binge and then let it fall away. Keep it up all the time.
I think that's right. I think that's the sensible message. A prostate needs a healthy body to live in as well. So it's no good looking after your prostate if you're going to have a heart attack, or going to have mental health problems or mental deterioration with dementia. So I think taking a holistic approach and doing sensible things that we know makes a difference to one's general health, I think is a very reasonable assumption that the prostate will also benefit.
Mm-hmm. What would you say to someone who's wanting to pursue a specific type of diagnostic measure or treatment that hasn't been offered to them?
Oh, well, I've had several queries today by such an individual. So I think everybody's entitled to a second opinion. I mean, unfortunately, the provision of prostate cancer care around the country is not symmetrically distributed. There are areas where it's easier to get some treatments than others. I mean, the good news about prostate cancer care for the UK, and this goes for Scotland and Wales as well as England, is that prostate cancer care is centralized now. You will be advised and treated by somebody that advises and treats lots and lots and lots of individuals, and you will go to a center that is excellent. We've passed the time where you used to go to your local hospital and there'd be somebody there that maybe looked after patients with kidney cancer, bladder cancer, and also did a bit of prostate. The people that are looking after you for treatment, whether you have surgery or radiotherapy, are professionals that have dedicated much of their professional life to doing that, and they work with groups of specialists that have also dedicated their professional life to that. So I think we're very, very lucky in the UK. Having said that, not all range of treatment options are available everywhere. There's a range of radiotherapeutic options. What's available locally may differ from what's available elsewhere. There are a range of surgical options. Transperineal robotic prostatectomy is not available everywhere. Robotic prostatectomy is now pretty standard, but there are various ways of doing it, as many people will be aware, and those different options aren't available. Not every option makes a material difference to the individual, and sometimes the newer options are very, very heavily advertised by the makers because they want people to have them done, and they are not necessarily any better, and so one has to be a little bit careful about that. Currently, the biggest asymmetry in terms of provision relates to focal treatment. So in other words, just treating the cancer plus a margin and trying to preserve the prostate. And that's very much distributed in the south. I'm not proud about that, but there are several places in London you can get it. Southampton, Basingstoke, I think Birmingham. But I think once you go north of Birmingham, it's quite hard to get a focal therapy opinion. And that's something we're desperate to correct. And we're happy to help anybody get up and running. We're helping people abroad. I was in Sweden recently helping the Karolinska start their focal therapy program. I was in Montreal recently helping them get their focal therapy program up and running. So we're always happy to help anybody get up and running. We're very supportive. But there is a disparity in provision in the UK that the powers that be know about, because we keep on saying it. Prostate Cancer UK are very aware of it. NHS England are very aware of it, and hopefully this will be corrected in time.
There's been a lot of talk about NHS waiting times. What are the waiting times for referral by the GP to actually being seen by a consultant?
Well, it's hard to be precise about that, because we've just had a junior doctor strike, and we just had a series of nursing strikes, and my clinic was cancelled during the junior doctor strike, and I think as a nation we lost hundreds of thousands of outpatient slots in those 3 days. So those patients had to be moved to other slots, which means that new patients will have to be moved to other slots as well. So it's very difficult. And I heard today that another junior doctor strike is being planned. So it's very difficult. And I think prostate cancer waiting times are amongst the worst of the cancer waiting times in the country, because there's lots of activity. Having said that, the waits to referral, should be as before. The GPs can still refer in a 2-week wait. Sometimes I think this week it's going to take a bit longer than 2 weeks to get that referral. And I think at the moment, certainly in our institution, we're from decision to treat, we're talking about a kind of 4 to 6, possibly very rarely 8-week wait, but 4 to 6 week wait before your scheduled date of treatment. Obviously, if you're having something like radiotherapy, you can start hormonal treatment straight away in order to prepare for it. And I think our waits for surgery are about the same. These waits will depend very much on local circumstances, and many areas around the country are still trying to recover from COVID-related waiting times as well. But it's not as we would like, but I don't think it's as bad as the very long waiting times that you hear for benign conditions such as people with hip pain or knee problems and stuff like that. They have a very long waiting time.
My last question is, what can we as sheds do to help raise awareness of the cancer?
Well, I think some things like this are fantastic. I have proof, as I shared with you earlier, that they work. That people obviously like the format. The format is obviously discoverable. So when people are searching, they seem to find men's sheds. So I would do more and more of this. I would invite, more people. I'm more than happy to come again and address many of the questions that we haven't addressed today. We could have debates. Again, I'm very happy to participate in a debate with a colleague about optimal treatment, optimal diagnosis, different types of screening, etc., etc. We're very happy to help, and we're very, very grateful to organisations such as Men's Sheds and other organisations for giving us the time to share some of our knowledge, so that hopefully individuals will get tested sooner, diagnosed earlier if they're unlucky enough to have prostate cancer, and therefore treated earlier and more appropriately.
Yes, well, on Monday this week, I represented the UK Men's Shed Association at the Tackle Prostate Cancer Workshop in Birmingham, and was very pleased to hear that Prostate Cancer UK have partnered with them to get the message out there. And I'm sure sheds will be hearing more about this in the weeks and months to come.
Yeah.
Can I thank you, Professor, for your time that you've done and given to us? Is there anything finally that you wish to add to what you've already said?
No, I think I just want to end on a hopeful message. I think there's a lot of negative things said about the NHS and healthcare. I think in prostate cancer, the UK is a true global leader. We brought MRI to the world. We brought focal therapy to the world. Colleagues, at Marsden and elsewhere have developed new drugs for men with metastatic disease, and have taken those to the world. So, I'm not quite sure why it is that we have been able to innovate and change practice so quickly, but we've changed the diagnostic pathway. We've changed the opportunity for men with metastatic disease. So there's lots and lots to be hopeful about. And I think we're going to start to address new questions, the immunotherapy questions for advanced disease, and the screening question that we've touched on, I think, is going to be another UK-led thing. So there's much, much to be proud of.
Oh, thank you very much for your time today, and I'm sure we will be in touch with you again at a later date.
Delighted to help. Yeah.
Thank you very much.